Good morning, everyone. My name is Sope Owoaje. For my presentation today, I will be covering my proposed evaluation for Nunavut's premier mental health surveillance system. Okay. I'm speaking to you today from ACKNOWLEDGEMENT Nunavut on Inuit Nunangat, which directly translates to the land of Inuit. I'm very grateful to have grown up and continue to live and work on this land, and I acknowledge the privilege I've been given as an uninvited guest on Inuit Nunangat. Before I start, I would like to mention that there will be discussions of suicide within my presentation. I would encourage each and every one of you to prioritize your mental health as needed. For my practicum, I worked with Sarah Farwadi, the mental health epidemiologist with the government of Nunavut, to implement the territory's first mental health surveillance system. During my practicum, I was able to complete a literature review on the issue, assist in the creation of the intake forms that would be used on our electronic health record systems, and training models for the frontline workers using the forms. Finally, I developed an evaluation proposal on the program. I'll be sharing this proposal with you today. As we dive into the proposal, I want to quickly touch on the importance of public health monitoring and surveillance on suicide surveillance. So why surveillance systems? Monitoring is a key component of public health models of prevention. It has been defined as the ongoing systematic collection, analysis, interpretation, and dissemination about a health-related event for the use in public health action to reduce morbidity and improve health. These systems allow for public health workers to determine the reasons why diseases occur, and holistic systems will include things like comprehensive, timely, and multi-source data collection within a population. Suicide monitoring works to seize all suicide deaths and related indicators in populations to understand the trends and connotations. This allows for improved planning, implementation, and eventual evaluation of public health practices. Real-time identification and prevention efforts. One of the top public health issues of our current time is suicide. It's one of the leading causes of death in the world, and is the fourth leading cause of death for youth aged 15 to 29. As per the World Health Organization, it's estimated that over 700,000 people die due to suicide every year. It's also found that for every suicide, there are many more attempts, making an attempt the single most important risk factor for suicide. Although suicide affects all groups of people, Indigenous populations have higher rates of suicide per capita than the national average. Inuit are one of the many Indigenous groups in Canada, and they inhabit the Arctic regions across the country, Greenland, and the United States of America. There are approximately 65,000 Inuit in Canada, with the majority living on Inuit Nunangat, which is made up of the four regions of Nunavut, Nunavik, Nunatsiavut, and Inuvialuit Settlement Region. Suicide rates among Inuit in Canada have been estimated to be about 5 to 25 times the national average. And on Inuit Nunangat, rates have ranged from 60 per 100,000 people in Inuvialuit to 275 per 100,000 people in Nunatsiavut. Young Inuit men are also 40 times likely to die by suicide than their male counterparts in the rest of Canada. Research on high rates of suicide among Inuit have largely indicated systematic factors resulting from colonization. These systematic factors include the historical trauma of residential schools, the consequent loss of language and culture, socioeconomic inequities, and government policies inflicting intergenerational trauma. To combat these rates of suicide, the Inuit organizations have been working to create suicide prevention strategies and support healing. So the Nunavut mental health surveillance system aids and aims to set a multi-tier system at the clinical and community level. The government is currently launching this program as a year-long pilot in Kugluktuk, a community that is seen as beneficial at this time. For the clinical phase of the surveillance, when a patient presents to the healthcare center, an intake tool or form will be completed by the community health nurse or the CHIN. The CHIN will then refer patients with mental health concerns to a mental health nurse who will complete a follow-up form to determine the case of self-harm and suicide attempt. Depending on the physical severity of the injury, some cases will see the mental health nurse directly. In the community phase of the surveillance, intake forms can be completed and submitted. The in-person follow-up will then be attempted within a 24-hour period of the reporting by a case manager. And the case manager will then refer individuals to mental health services and other community-based providers. The pilot is going to be evaluated to determine whether the implementation of the program is successful by assessing the number of forms submitted on the electronic health record system and whether they're being used effectively within the clinical setting. There's to be a two-part evaluation during this pilot. The first evaluation will take place shortly after the pilot has been launched, approximately 3 months, and the second part of the evaluation is to take place approximately a year after the pilot has been launched. Components of the pilot that will be evaluated during the first phase will include things like the number of forms being submitted through the clinical settings, the quality of the forms being submitted, the performance of the case manager, and feedback from the mental health nurses and other frontline staff. The component of the pilot not being evaluated during the first phase will include feedback from community partners and the program efficacy for expansion to more communities. All these components are to be evaluated in their entirety for the phase 2 evaluation. As the system is working to impact communities around the territory, it's important to identify stakeholders to the program. Their identification within program evaluation is of importance, as they can ensure the right questions are being asked during the evaluation and that the results will be supported to make a difference within the current system. To identify the major stakeholders, we're using 3 categories as recommended to us by the CDC. In those involved in program operations, those who are intended users of the evaluation program, and those served or affected by the program. The main question of our evaluation is, can the mental health surveillance system be used effectively to track mental health concerns in the community? The evaluation will work to answer following complementary questions regarding the efficacy of the program implementation. So firstly, how is the mental health surveillance system being implemented? Are the forms being completed accurately? To what extent has the system produced unintended outcomes positively or negatively? What is helping or hindering the implementation of the system to achieve its objectives? And finally, how is the mental health surveillance system contributing to family and community strength on a short-term and long-term basis? These questions identified will help the evaluators to determine the type of data to collect and how to effectively answer them. We're using a before-after pre-post study process, and in this non-experimental design, the surveyors can use already available data from the department electronic health record system to draw comparison pre and post implementation of the program. We think this is a suitable study as this is a new program of its type to the territory. The program will uphold certain indicators and standards to determine the feasibility of the program. Indicators that the pilot is being implemented successfully will include proper completion of the forms by the nurses, documented initial contact with patients within the first 24 hours of report, improved follow-up among clients with suicide ideation, self-harm, and/or attempt, and community awareness of the program. As this is a pilot program, we're not yet aware of the amount of forms to be completed. There's currently limited information, but for future evaluation, the quantitative figures will play a role in creating more in-depth indicators. Data from pre-intervention has been collected by the government to determine the need and indicators for the program. Evaluators will have access to the health record system to view the number of forms being submitted since the start of the pilot. They'll also be making use of this access to determine quality. The operation lead and the evaluator will meet with piloting areas to engage in community consultation and allow them to determine if the community will continue to support the use of the form and any suggestions to the current program. Evaluators will also meet with the case manager to discuss the flow of the referrals. Feedback from the case manager will aid in any reconstructing that may be needed. Case classification will be conducted by the mental health epidemiologist based on already agreed suicidality definition. A questionnaire will be available to patients to determine if the resources currently available are beneficial and to gain more understanding of population need for ongoing resource accessibility. Though the implementation and evaluation of this pilot program, or through the implementation, we're hoping that there'll be increased and accurate tracking of self-harm and suicides within Nunavut. We hope to encourage an increased awareness of mental health knowledge and resources within the community. And once evaluation has been concluded on the pilot year in Kugluktuk, the operating department hopes to able to slowly implement the program right resources and staff for program effectiveness. Increased understanding of the numbers will also improve evaluation of suicide prevention interventions and allocation of the resources where needed. This program hopes to lead the way for additional research to be completed on surveillance systems within other Indigenous communities across Canada, similarly implementing clinical and community tools to facilitate healing. Thank you for listening to my presentation and for being present. I want to express my gratitude to my practicum supervisor, Sarah, and the Department of Population Health as a whole for really welcoming me into their very complex world. Dr. Catherine, Dr. Jaime, for your patient and extensive guidance throughout my project. And of course, my family for supporting me through my many anxiety-ridden moments. I'll now take this time to answer any questions or comments from any of you.